So we're responding to a 40-year-old male who fell off a roof of a building while water blasting, and it happened to be roughly of 6 meters high, and and he fell on a concrete pad. So he got spotted by his neighbors. Unfortunately, the neighbors are not fit enough to be able to assist us in this situation. So while responding to this patient, I'm just going to go through differential diagnosis. Potentially, the patient could have had the fall secondary to a stroke. He could have had any different illnesses that he had previously. Well, he could be hypoglycemic and so on. So I'll just have to keep these things in back of my head while I'm assessing and treating the patient to know why did the patient actually fall off. It could be as simple as slipped off. So on arrival, I'm just checking out the scene's safety. I'm assuming for the case of this scenario, everything's going to be safe, and I'm just going to be able to approach the patient, and I'm just going to carry on with assessing them. So when approaching the patient, like I'm calling for their name, hello, can you hear me? And I'm just applying a little bit of pain to see if they're responsive to pain, and I don't feel anything. So I'm just going to be checking their airway. Airway looks clear and patent. There's no foreign objects that are blocking it. The breathing seems a bit on the slow slide, and it seems as if it's irregular as well. Circulation wise, the patient so far looks somewhat well perfused, with crab refill sitting about 2 to 3 seconds, and centrally warm as well. So while I carry on with my primary and secondary survey, I'm just going to ask my offsider to carry on a full set of vitals, which will include a heart rate, blood pressure, respiration rate, a blood glucose level, and as well as temperature, please. So while he go on, please inform me whenever you have these set vitals ready for me, please. So due to the nature of the heart and the CPGs listed in St. John's CPGs, I'm going to be treating this patient as a suspect of TBI, which I'm going to have to maintain a systolic blood pressure of 120 and make sure I don't actually exceed that, just to make sure I don't cause any further damage to the brain and so on. So well, I'm going to be assessing the patient with my primary survey. I'm just checking for neck tenderness. I don't feel anything very tender or C-spine injuries. There's a little bit of small pooling of blood around here, which is roughly about 6 centimeters in diameter. So I'm just going to carry on with assessing this patient. So I'm just feeling for any trauma, obvious deformity, as well as any other signs of bleeding anywhere else. So I'm just feeling everything feels tender and alright, palpating the stomach. The chest feels intact, and I can see a bilateral chest rise, which minimizes the chances of having a pneumothorax or tension pneumothorax. So I'm just going to carry on feeling the hips. Everything seems intact. That's good. So I'm also just going to put my hands under the patient's back. Just going to lift him slowly and give him a quick feel and see if I'm feeling anything out of the ordinary. And now everything feels right and intact. So I'm just going to put that dot on again. So can I get these set of vitals, please?
Yep, so heart rate is 50, BP is 160 or 90, wrist rate is 12, BGL 7.6, and his temp is 37.
Alright, so I'll just request for my offsider to request an R50 for an RSI, because at this stage, due to the regular bleeding, we might need to be intubating the patient, just in casing that there's a high chance that the patient might be going into cardiac arrest. So, thank you. So I'm just going to put these nasal prom on. Just tuck it in. Awesome. Oh, he doesn't even have these. Sweet. So, and look, assessing the patients as you go, to me this patient looks bradycardic. He's hypertensive due to the blood pressure of 160/90, and respiration rate is a little off, and because especially it's irregular, and blood glucose is sitting right, so sitting at 7.6, which is normal, and temperature is sitting within the normal range. So I'm not suspecting any sepsis or other form of the illnesses or hypoglycemia or hyperglycemic event to explain the fall. At this stage, we have no other factors to explain the fall besides the patient has slipped off. At the moment, his GCS is obviously sitting below 10, and at this stage, I'm going to be assessing the patient with his airway. And at this stage, I'm just going to ask my offsider to put on an OPA and just get my bag mask and stuff ready while I'll go draw out my drugs. My drug is going to be 1 ampule of morphine, which is 10 milligrams in 1 ml. I'm going to be getting that 1 ml out, and I'm going to be diluting it with 9 mils of saline, which is going to give you a 1-to-1 ratio. So 1 mil in every 1 milligram in every mil delivered in that syringe. So obviously we're going to drop check. So just checking, making everything's alright. Awesome. So with the bags, we're going to also have the PEEP on. We're going to have to set it up 5 centimeters 5 centimeters due to the suspect of TBI. And yeah, just going to be ventilating the patient as we go on. We have connected the ETCO2 to also monitor the respiration rate, as well as to make sure that the blood is actually circulating around, oxygen is going in and out, and as a result, carbon dioxide as a result is actually exiting the body, and trying to make sure that patient is ventilated and breathing well. So as we go with this, I've prepared I've rested his head on a couple of towels to make sure I have my chin lift and jaw thrust position to make it easier to ventilate. So since now we have our OPA and stuff on, and we have the suction also ready. If I just can get you to test out the suction for me and make sure it's actually providing enough power as it should be. We also have set up our fluids, and we have access to our bilateral IV access. However, no fluids that should be administered at this stage due to the patient being hypertensive at 160, and we're trying to maintain a systolic blood pressure of 120 due to the TBI. So I'm assuming that the suction is working well, and we have our IVs in. Obviously fluids are not. So due to the patient being having an isolated injury, on he obviously has an obvious funky patch, he's obviously restless and also competitive, so I'm going to be administering 4 milligrams of morphine for that competitive, and be able to proceed with ICP, applying his RSI and preparing the scene for my ICP. And yeah, we're just gonna continue getting another set of different set of vital signs to update my ICP, which we're gonna meet en route. And we're also just gonna go through our checklist with my offsider while I continue ventilating the patient. So if you may.
So, preparation for RSI checklist. Attach nasal prongs without oxygen.
Done.
Pre-oxygenate using a manual ventilation bag at 10 to 15 liters per minute with PEEP set at 5.
For the case of this scenario, we haven't actually ran the oxygen because we don't have enough oxygen. But in a real life scenario, we'd be running at 10 liters per minute.
Attach ECG, NIBP, and SpO2.
Done. That's all attached.
Prepare capnography if this is available.
Mm-hmm.
Position the monitor so that it can be seen, leaving space to the right side of the patient's head for intubation equipment.
Happy with the monitor position?
Gain IV access, preferably in 2 sites.
Yeah, we have accomplished that.
Prepare a running line of 0.9 sodium chloride.
Yeah. Ready.
Position the patient for optimal airway control. For example, consider placing a folded towel under the head.
We have two towels on the patient's head to help us with that.
Place an ETT holder with the strap undone under the patient's head.
Done. That's also done here.
Ensure suction is working and turned off.
We have also tested that out previously.
Prepare a manual ventilation bag with PEEP valve attached if not already in use.
It's already in use.
Obtain a set of vital signs.
Vital signs have been accomplished, and another set of vitals will be taken in the next few minutes to update my ICP.
If possible, update the responding ICP with patient's condition and vital signs.
As I said previously.
Prepare the area. If the patient is not in the ambulance, clear the area so there's access to both sides of the patient.
So en route to the ambulance, I'm gonna make sure that the ICP will have enough space around him for him to fit his equipment and to comfortably sit down and apply his RSI skill. Sorry.
Preparation RSI checklist is complete.
Yep. So by going through this checklist, I'm happily to confirm that the checklist has been completed successfully. So on arrival of the ICP, we're trying to prepare and help with the process of the RSI. But we can help the ICP by applying the acronym of BERP, and that's backwards, upwards, rightwards pressure. And you do so by holding a appendix finger on the right side of the trachea and your thumb on the left side, and you push downwards, then you push upwards and rightwards, and so it should help with exposing the vocal cords. That will be in the same time as the bougie being inserted in a way where to expose the epiglottis for the ICP to be able to insert the tube. However, we can also keep in mind that the bougie remains inside until the tube is actually inserted and secured. So in case of failed RSI, we're gonna have to, or we're unable to visualize the cords in 15 seconds, or unable to intubate within the first 30 seconds of the laryngoscope, and we're gonna use a different pathway, so like basic life support airway, or otherwise, if we managed to get it in and there was no changes in ETCO over than 5 mmHg, after 2 to 4 ventilator breaths, then we should be removing it straight away and administering OPA or LMA. Since the OPA or LMA is inserted after that, if it works, we'll remain with that pathway of that basic support. However, if it fails, then we're gonna have to follow our last result, which is CREC. And what happens in that case is the ICP will have to make a cut here, an incision of a tube down the trachea to be able to ventilize the patient and control the airway for them. This scenario would be sending to a patient with chest pain. However, for the sake of this scenario and the limited time I have available, and I don't have my offsider on me, I'm going to be minimizing a few things. For example, I've already set up everything that I'll be setting up on the rep, including my pads, my sticky dots or electrodes, blood pressure, SpO2, and so on. I've also, for the sake of this scenario, I'm also going to assume the safety of these all up to measure. I'm wearing my glasses, gloves, seen as safe and approachable. Put me on my offsider. So en route to the patient, me and my offsider will be discussing differential diagnosis of chest pain, because it can cause you could have pulmonary edema, pulmonary embolism, could have breast cancer, could have infection, or and so on. So there's a lot of differential diagnosis. So when entering this scene, we have to enter it with an open mind and not just quickly minimizing it or pointing it out to be a cardiac event straight away. So now, assuming that we arrive to the scene and everything is safe to approach. Now, hello Sam, can you hear me? Can you hear me, Sam? Hey, can you tell me what's happening?
I have chest pain and I collapsed.
That's okay. Can you tell me how bad the pain is?
It's really painful, like an 8.
So I'm just feeling for a pulse. I can feel that it's very tacky. Hey Sam, is it okay if my offsider just go get a full set of vitals and I continue on assessing you?
Yeah, it's okay.
Alright, so as I'm continue assessing my patient, my offsider is going to grab a full set of bulbs. So Sam, can you explain that pain for me, please?
It's just really painful and I can't stand. Every time I do, I collapse and I get dizzy.
Were you doing anything when it happened?
I can't remember.
Okay. Do you have any medical discharge forms from the hospital?
No,
Do you know your medical history?
But I did have a MI 5 years ago.
Alright. So just a general impression looking at the patients, I can notice that he's a little pale, a little sweaty, and a little confused and agitated with the condition. Hey, can you tell me if the pain is radiating anywhere, Sam?
Just up my neck.
So
Feel palpitations.
Are you allergic to anything?
No.
Alright. And are you on any medication at this stage?
Yeah, clozapine and aspirin.
Okay, clozapine, that usually indicates a case of heart failure or hypertension and so on. So at this stage, I'm just going to ask my offsider to see what the vital signs are. So can I get the vital signs, man?
Yeah, it's 170. Heart rate is 170. BP is 70/40. Rest rate is 18. BSL, BGL is 7.6, and temperature is 37.
All right. So since my only abnormal symptoms at the moment are my heart rate, it's a very tachycardic, and he's a little hypertensive. So at this stage, I'm just going to lower my patient down to the supine position, and I'm also going to raise the feet and hopefully to accomplish an increase in zero to hopefully increase the blood pressure and increase and improve the perfusion for in this case, in this patient's case. So while I'm also continuing assessing the patient, I'm going to be asking my offsider to call for an R50 for in case of peripheral arrest, and as well as for him to draw me my drugs or pain relief, which is fentanyl in this case, as morphine is not indicated due to him being cardiovascularly compromised. So I'm just going to grab the solution from my offsider. So in here we have a 10 ml solution. We have 1 ml of fentanyl, which is 10 milligrams, 100 micrograms of fentanyl, as well as 9 mils of saline. So it's sitting at a ratio of roughly 10 to 1. So 10 micrograms to every 1 mil. So at this stage, due to the very severe pain that the patient is having and the agitation, I'm going to be administering 40 micrograms. Hey Sam, have you had fentanyl before?
No.
Alright, so this is just going to ease up your pain, alright?
Okay.
So I'm just going to administer 40 micrograms. And awesome. So as after administering this, I'm just going to ask my offsider to reassess the patient and get another set of ops while I'll be preparing my cardioversion, as I believe this patient needs one immediately, while we're also waiting for our backup as well. So while we're setting up our cardioversion, I'm going to be needing my offsider to read out my cardioversion checklist. However, due to not having my offsider in here with me in this scenario, I'm going to just be reading it out for myself. So initially what I want to do is I'm going to be turning my monitor on, and I'm going to be selecting in the manual mode. So after I put it in the manual mode, I'm also going to be selecting it on max joules. Here we go. Manual mode, max joules, and I'm also going to put it in a 3 lead to visualize it and make it most appropriate for me to be able to see the complexes more clearly and accurately. So just sorted that out. I'm gonna click sync to synchronize the rhythm, and hopefully to be able to identify a decent QRS complex to match up the R waves. So just syncing now, and I'm just gonna be printing out print, make sure every QRS complex has a simple detection above it. Just checking. Yeah, by the looks of it, it's matching and it's good to go. So we have synced out a rhythm for the patient. So I'm just going to read it out before I shock it as my my checklist. So place pads in either the apex or the apex and sternum or anterior posterior position. We have accomplished that. Ensure the defibrillator is in manual mode. LS. Select the lead which is visible R wave and ensure that artifact is minimized. We have achieved that by changing the leads and exposing the better leads, which show us the complexes more efficiently. Select sync nodes. We have done that. Confirm there's a detection sample above every QRX, which we've done that as well. Ensure the patient has received adequate sedation if indicated. We have administered 40 micrograms of fentanyl. At this stage, I'll ask the patient what pain score he's sitting at. Hey Sam, can you tell me what's the pain's doing now?
It's good. It's around
Is it
about
better?
4.
Setting it at 4. So I'm happy to leave them as it is at the moment. So ensure that select the joules. We've selected the max joules. Charge the defibrillator and confirm that everyone's clear. So at this stage, I'm going to press charge. Pass off again. Alright. So we press charge. Alright. And as it's charging, please press hold and shock the bottom until the shock is delivered. So I'm making sure everyone's clear, looking at the clear, and shocking the patient. So shock is delivered. Determine if the rhythm and the level of cardiovascular is still compromised. So at this stage, I'm looking at my ECG, and to me, it still looks very tacky and very cardiovascular compromised. So at this stage, I'm thinking of shocking the patient again, or in other words, retry my cardioversion. Hey Sam, unfortunately the first one didn't work. Can I try another one on you, please?
Yep.
Alright, so we're just gonna follow the same steps, placing the leads, ensuring that everything is intact. We're gonna synchronize the waves. Oh, it's still synced. If it wasn't synced still, we're gonna have to redo that. Resync the rhythm. However, it is in this case. We've already selected max joules, and the pen is sitting at the same, just before, sitting at full. So I'm just gonna recharge again. So charging, and it's charged, stay clear, and shocked. So shock's delivered. I'm looking at the rhythm now. It looks like it has resolved itself. In the case of in case of this patient has not resolved of this rhythm, we'd also be waiting for our ICP, or maybe even try to contact the clinical desk to try explore the chemical or pharmaceutical options to administer drugs which could help potentially to revert his heart rhythm. But yeah, at this stage, since Sam has gotten his rhythm back and he's no longer cardiovascular compromised, I'm happy that I'm not going to be cardiovert again. And yeah, so I'm just going to get another set of vitals with the patient and make sure everything is still normal, and we'll be transporting the patient to hospital and potentially even meeting our ICP en route if any issues have arisen. I'm also going to auscultate the patient chest just to rule out potential pneumothorax, even though there's bilateral chest rise, but also pulmonary embolism, etc. And just make sure he doesn't have any crackles or stridor or anything. So Sam, I'm just gonna quickly listen to your chest, mate. Take a deep breath for me. Take another one. Another one, babe. And another one. Awesome. It sounds clear and patent.